assess the vaccines. So for me, the point I'm trying to make here is that communication is very key in that building that confidence and making people have that informed knowledge about picking, deciding to vaccinate or not to vaccinate. Next slide, please. So good communication skills is a must for healthcare workers. So healthcare workers need to have good communication skills to actively keep up to date with the latest evidence. So an understanding of their own perceptions and experience of vaccine communication can help train and support healthcare workers and design good communication strategies. So it's important that a patient comes to you should leave better, not more confused, not more emotionally stressed, but they should leave better because you have excellent and compassionate communication, which should be part of the cure. Next slide, please. So looking at just a quote to say that it's important that healthcare workers consider each individual's needs, views, and levels of understanding and tailor information about vaccination accordingly. So they also need to communicate this information in a way that is accessible. To have these skills require training, support time, opportunity, and self-awareness. And during this pandemic, I know that the urgency of the situation can make it really difficult to meet these requirements. And although prior training, skills, and awareness of vaccination communication in general are likely to be helpful. Next slide, please. So there are two extremes sometimes that happens when it comes to patients and vaccinations. You have patients who don't ask about vaccines at all, and then you have patients who demand a lot of information about vaccinations. And when the topic of vaccination is being discussed, some healthcare workers describe a lack of information on that, and of course, the presence of misinformation and lack of concerns among vaccines about vaccines among patients. Next slide. And their reaction to this varies. So on the other hand, the way in which the healthcare workers discuss vaccines with patients appears to be linked to what they saw as the aim of the vaccination communication. So it differs amongst them in their perception about their aim and about their own rules and the rules of the patient in vaccine decision. So some healthcare workers think it's
Absolutely.
important to provide information what emphasize on the rights and responsibilities of the patient to decide for themselves. So the patient decides, all they do is say, this is the information, these are the vaccines available, this is what the vaccines do, these are the efficacy, this is the side effects. So decide what you want to do for yourself. And the other people use the information to persuade, they try to convince the person to try to all of this to improve vaccination rates, compliance, sometimes also to gain financial benefits because in some places the more you vaccinate, sometimes it comes with financial benefits. And sometimes on the other hand, you have healthcare workers who their approach is what they believe the patient's needs and wants. So they tailor their approach to what they believe the patient needs or wants at that moment. Next slide. So, as a case study, many healthcare workers, of course, encouraged to vaccinate themselves in order to protect their patients. So, there was this case study about employers that suggest that they are influenced by many the same issues as the patients when deciding whether to vaccinate themselves or not. So these include the perceptions they had, include their susceptibility to influenza, the severity of influenza. Like for example, COVID. If you For a healthcare worker, they will always think first, am I likely to get COVID? How severe is it going to be? How efficacious is the vaccine? What are the possibilities of a side effect? So these perceptions as well happen with healthcare workers, and that also affects the way that they also communicate and relate with the patients that they work with. So some of them justify their views with reference to scientific evidence. Of course, others are going to justify their views about health and a belief in authoritative therapies, of course, and refer to non-standard views. Next slide, please. So it's important to know that as the healthcare workers' perspective on vaccinations are likely to influence communication with patients, the healthcare workers need to be aware of their own perceptions if they are to support the informed decision making among patients. These are not small demands and they require training, support, time, opportunity, and self awareness. Next slide, please. So, healthcare workers believe that patients' decisions can be influenced by several factors. First of all, the nature of the healthcare worker and patient relationship, the healthcare worker's status of knowledge, the extent to which the healthcare workers lead by example. We've talked about the case study of, vaccinating themselves, the willingness to vaccinate themselves at first before even having that conversation with other people. And also when you talk about status and knowledge, how knowledgeable are they about the vaccines and all that, to be able to impact that knowledge to the patients that they're talking to and having the conversation and communicating with. Next slide, please. So influences on how communication between healthcare workers and patients take place. So these included issues tied to the healthcare workers' views and experiences regarding the diseases in questions and the vaccines, views and experiences of the organization and practical implementation of vaccine services. So this is just to determine how they regard the disease. Do they perceive the disease as something serious or not serious? Do they see the vaccines as something efficacious or not efficacious? So that's going to affect how they communicate and how they try to persuade and how they try to influence the patients in taking the vaccines or informing or making that informed decision about that. And of course, the implementation of the vaccine services also plays a key role in how this communication between the healthcare worker and the patient takes place. Next slide, please. So implications for practice. This is just a general list of sort of like questions and some considerations that in practice, but when we're trying to influence or when we're trying um, to get patients to take vaccines or get vaccinated? Are we looking at the patient's rights and preferences? Are we paying attention to that? Has there been enough communication training from the healthcare workers' perspectives? Are there awareness around the influence the healthcare workers have on the patient and the knowledge they have? How is the healthcare workers' vaccine uptake? On the continent now, they're just about 4.3 million. From the data we have from 38 countries, there's just 4.3 million healthcare workers vaccinated from the data we have, and that's not enough. So that also shows that, there is also some vaccine hesitancy on the part of the healthcare workers. And so that will, of course, play a role in they being able to convince patients to have take vaccines. Part of the healthcare workers' role, of course, is it part of their role to encourage? Do they realize it's part of their roles to encourage patients to take vaccines, the COVID-19 vaccines? Do they have access to patients' data to encourage them to take vaccines? Is there an established relationship between the patient and the healthcare worker, be a pharmacist, be a doctor, a nurse, a therapist, a physiotherapist, anybody in the healthcare sector who is liaising with the patients? Is there a really established relationship that can foster that communication between them? Initiating this conversation, of course, has to be based on the fact that there's an established relationship and the context within this relationship is happening. And of course, the disease information is very key. So, like I said, there's so many ways we have taken this conversation. One would have been to just give a whole lot of scientific information about COVID-19, the research and all that, which we can do on another day, which is a whole topic on its own. But the healthcare worker needs to have that disease information, have that information about the disease and about the vaccine, and be able to address the key concerns of the patient, and of course have the vaccine information. And is he or she in agreement to the recommendation of the health institutions or the public health institutions and health regulatory authorities have given on these vaccines for the patients in question? Next slide. So that's all from me. So I'm going to be in the chat for questions and answers on the core issues around vaccine research and questions around the vaccine information itself. Thank you very much. Over to you, Lizzie or Anna.
Thank you, Zini. Thank you for this information. It was great to hear, and I'm sure there will be a lot of questions. I'd like to introduce Professor Jeff Dorfman. He's an associated professor at the medical virology at Stellenbosch University in Cape Town, and he's written about COVID vaccines and the national policy in South Africa. So I'm going to hand over to Professor Dorfman to take us through his presentation on the vaccination. Thank you, Prof. Dorfman.
Okay, good morning and good afternoon to everyone. Thank you all for joining. My place here is to try to give you some of that information for a better understanding of what we as scientists are learning and what we know about vaccines. As I'm sure you all realize, if you have doubts about vaccines, it would be very hard to convince or to know you wish to convince other people to take the vaccines. So I would like to start that conversation. I put my email address here. Please do write it down. In principle, you can get the links if you download my slides, but my presentation is very large, so I'm not sure everyone will be able to download it. And if they have that or matters you wish to discuss, please do email me. I apologize if I don't respond right away. If I don't respond in a couple of days, please, if you'll email me second time to remind me, I'll appreciate it. So with that said, I think I want to spend about the first 4 minutes or so talking about what the vaccines are and how they relate to what we already know about vaccines. So the first, and possibly at this point the most famous type, is the messenger RNA vaccine or mRNA vaccine. So this is the Pfizer-BioNTech vaccine and the Moderna vaccine. So messenger RNAs are what we in every cell in our body that makes protein. This is the blueprint for that messenger RNA. It's the blueprint for that protein. It's how we make it. It's how we know how to put it together. Our cells know how to put it together. The vaccine itself in these cases is made up, the key component is this messenger RNA. It's coded and packaged, otherwise it wouldn't last, it would just degrade. So it has other ingredients as well. And this vaccine, when it gets into the cell, the messenger RNA acts like all of our own messenger RNAs, and it directs production of a protein from SARS-CoV-2. And then we make an immune response to that, which includes antibodies and T cells and B cells. Then this one is sort of in a sense the newest, but I want to assure you that this has been a type of vaccine that has been studied by scientists for many years now. And there are many people who've received it as parts of trials and studies, and we know quite a bit about it. And now after COVID, we know a lot more about it, and I'll share some of that with you. The second type of vaccine is the adenovirus-based vaccine. Adenovirus is a virus that we all have all around us. It causes the common cold in people. It's a natural virus of humans. And what scientists have done is taken one or another type of adenovirus. They turn out to be the best to use for this. That's why they're used here. In over 30 years of research of using innocuous viruses for vaccines, adenovirus seems to be the best. And so we take an adenovirus, we remove part of the virus and part of what it encodes for, so it can't replicate, it can't make more of itself. It also can't cause disease. And we insert the genetic material for the protein we wish to immunize, in this case, SARS-CoV-2 spike protein. This enters a cell, The cell then starts making messenger RNA from its DNA and then makes protein. That protein is part of the immune response. And the vaccines that work like this include the Janssen vaccine or Johnson & Johnson. It's just two different related companies. I think one owns the other that make one vaccine. The AstraZeneca vaccine that was developed at the University of Oxford, the Covishield vaccine made by Serum Institute of India, and the Sputnik vaccine from Russia and the Sputnik Light vaccine from Serum Institute of India. These are all adenovirus-based vaccines. Then we have the vaccines that look more like vaccines that you have all seen before that are licensed for use. There's the inactivated vaccine, just like the Salk polio vaccine, the one that is a jab, not the drops. Influenza vaccines, rabies vaccines, hepatitis A vaccines. These are all inactivated vaccines. The COVID vaccines are Sinopharm, Sinovac, and Covaxin from India. So what one does is one gets cells to produce a virus, in this case SARS-CoV-2. We then kill the virus experimentally in culture and use that material to make a vaccine that becomes part of the vaccine, and that makes the responses with antibodies and T cells and B cells. Then we have protein subunit vaccines. Some examples of the protein subunits vaccines we already use are tetanus and hepatitis B. And what we do is we have a virus. The virus has a spike protein that's on its coat. Excuse me, let me just go. There we go. And what scientists do when making this vaccine is you make just that spike protein. And then that becomes part of the vaccine that engenders an immune response. Examples of protein subunit vaccines include Novavax and Corbevax and Soberana. The only one that is in common use of these three, to my knowledge, is Soberana. I don't think Novavax or Corbevax are licensed for use yet anywhere. I may be wrong. I'd like to be wrong because Novavax I know of is a nice vaccine. There may be others, and if you email me, I can research and tell you which category it falls into if you like. I'm trying to cover all the vaccines that could possibly be used anywhere in Africa, and there are a lot of them. So let me go back a bit to the beginning only, or probably in some ways the middle of the vaccine story, the original vaccine story. This is one graph from the data that Pfizer, the company, showed to the United States Food and Drug Administration. They presented the data in November. It was evaluated in December from one of their first phase 3 trials of 42,000 people, followed up for a median of 2 months. And what does this graph show? So we have two groups here. We have the group that got the vaccine here in blue. We have the group that got the placebo, which was they got a jab, but it didn't contain the vaccine. During the study should not know who they are, nor should the people who analyzed the data know who they are, who is who, nor the people who gave the vaccine should know who is who. And what we have is the cumulative incidence of SARS-CoV-2. The dark dots are more severe cases. I forget what the precise definition was. So as time went on, they saw more and more cases. But starting at around 10 days to 2 weeks, these curves diverge. And you find that there are many, many fewer cases in the people who got the vaccine. This translated to about 95% protection, which means about 95% of infections were averted. So that's where we started. This looked really good and still looks good, although it's not quite true anymore now because of our variants. And I'll go through some of that. So this is in the beginning. This is only about a year ago, starting about November, December 2020, and extending probably till about March 2021. This is when data from the first very big efficacy trials, vaccine efficacy trials, were coming out. And we were seeing that the vaccines really worked, which until that point, you couldn't be sure. The Pfizer, Moderna, and Janssen vaccines were the first ones to release these trial data, and these were the first ones to be licensed in a lot of Western countries because of that. 95% efficacy from infection meant that what I'll call herd immunity, without defining it precisely, by vaccination looked like something you could have. What you expect out of vaccines. We vaccinate well enough for measles, you don't see many cases of measles. That is a simple, not quite a definition of herd immunity, but that's what I think people understand when you say herd immunity, and they're not really fundamentally wrong. But things have happened since then that modify this all a bit. First of all, even then, we knew that the follow-up was for an average of 2 months, so there was no data on how long immunity would really last. The short answer is it lasts very well if you're looking for immunity from severe disease, immunity that prevents hospitalization with COVID, immunity that prevents death from COVID. That immunity seems to last. Immunity against infection, we have a more complicated story, and I'll tell you more about it, but I don't think it's entirely gone. It also did not account for the variants that had not yet been seen at that point, that seemed to be selected to partly evade these antibody responses and the immunity generated by infection with what I'll call the original variant or parental variant, or by the vaccines. So we'll see a more complicated story, and that's what causes some of the communication problems, and I'm going to try and talk about that and dispel kind of uncertainties and give you enough information that you can even look for yourselves at the data and try to understand better what has happened and what do we understand. I'm going to, before I do that, I want to answer one question that's on many people's minds that I get asked a lot. How do we have COVID-19 vaccines? COVID-19 was understood as a public health problem in December 2019. And by December 2020, we're already approving a vaccine. 1 year. How did that happen so quickly? HIV, we've been studying for 40 years. Malaria, tuberculosis, even longer. How did this happen? Is there something suspicious about this? And no, I think my answer is no, there isn't something suspicious about this. And let me explain why. First of all, there were many little things that helped us along, and I want to go through what some of them are. The experience from SARS-1, everybody hopefully remembers SARS-1 that happened in Asia about, when was it? About 15, 20 years ago. And that never was infectious enough to really stay in the human population. And MERS, which also, these are very closely related viruses, and vaccine development for those viruses had started. Some of the data used to plan Moderna's vaccine phase 1 trial came from SARS-1. It actually made the Moderna vaccine available faster because the process was faster. If you have a year to develop and test a vaccine, everything that saves you 3 weeks here, a month here, that adds up and becomes very significant. And that was one part of it. The sequence for SARS-CoV-2 was publicly available in January 2020. The Moderna vaccine went into small cell production for research trials the very next day. I didn't learn that until May, but that's what happened. Okay, that was something that couldn't have been done for any vaccine 20 years ago, 30 years ago, and it was information that even wasn't always available very quickly. 20, 30, 40 years ago, you couldn't do this. Timelines were accelerated. This is part of it, but even more than that. Phase 3 trials were planned and put together, funded, even before phase 2 trials were completed. Vaccines were in production before phase 1 trials were completed. Some companies spent tens of millions of dollars, even hundreds of millions of dollars to produce vaccines at scale, even before the first vaccine went into a human arm in a trial. That's a big risk and something that never happened before. But people were watching people die everywhere in the world. And some companies, you could say, they also made a calculated risk. The risk of not being first, if you're a company that has a possibility of being first, is greater than the risk that you will take $50 million and you're making a vaccine that turns out to be worthless and it's all gone to naught. That was a smaller risk than being slower in the race. That's how they perceived it. Everybody also wanted a vaccine as quickly as possible. People were personally afraid. People were afraid for people around them. Everybody wanted a vaccine and everybody wanted it fast. Everyone was paying attention. It was easy to find trial partners. So imagine I'm now Moderna or Pfizer or Janssen, and I'm now calling up all my trial partners and I'm saying, can we get a commitment from you to run part of our trial in your country? And I can tell you, I was not part of any of these conversations. I can tell you one answer they didn't get. The answer they didn't get is, we're very busy right now. Maybe can we do it in February 2023? That answer, nobody gave them. Everybody, everywhere was watching people die. Okay, so that might have been the answer they got for a malaria vaccine. Everybody knows these candidate vaccines, they've all failed before, all of these things. It's not a likely thing to happen, and they wouldn't make time. For this, everybody made time. Everybody put in the effort, and everybody all at once. And I think these things were critical. Without all of these things, it wouldn't have happened in a year. But these are all the small reasons. There is there's one more thing. I'm going to step back. One more small reason. A phase 3 trial of COVID-19 vaccine, once you're immunizing people, can produce data in about 3, probably more realistically 4 months. This can't be done with an HIV vaccine in less than 2 or 3 years. Everything happens slower. You can't just wait 2 months and see who acquires HIV, because everything all takes longer. So that also matters. It's also a difference. But as I was already saying, these are all small reasons. The big reason was it was easier to make a working vaccine. And let me explain what I mean by that. Everything was easier. And here I'm going to give you a critical example. It is not the only example. It's just simply the easiest and the best example. So this is from a poster at the American Society of Tropical Medicine and Hygiene meeting in 2012. It's from one of Johnson & Johnson's collaborators. It's about a malaria vaccine that was put into adenovirus 35, so ad35 and ad26. They were already, by this time, working quite strongly with ad26, which is one of their successful COVID-19 vaccine. And what did they do? They told us that it was well tolerated, it made nice immune responses, but in their conclusions, they immunized 17 people and only one of them was protected. So this poster never got published in a peer-reviewed journal. This vaccine was dropped, and all the people working on it went home then and cried into their beers and got over it and moved on to do something more productive. It just didn't work. They also used ad26 to make an HIV vaccine. This was an exciting vaccine. I can tell you, I was in Rotterdam for a visit in 2018 when they finally got the go-ahead for a phase 3 trial of this ad26-based HIV vaccine. Ad26, the very same way, same vector, same approach used for the successful COVID-19 vaccine. And about 6 months ago, they pulled the plug on the trial because it didn't work. So here we go. We have exactly the same vaccine approach. We have over a decade working with ad26 that told them a lot of things about ad26. They didn't have to work those things out again for COVID-19. They were already worked out. How does the vector work? What sort of dose range? What kind of immune responses? How do you measure them? All these little details were all worked out. But with vaccines against HIV and malaria, that didn't work. So the simple answer is, it was easier. It was much more achievable. These approaches that were spectacular failures for HIV and for malaria was a very good success in making an effective vaccine that many of us have had, including myself, and are protected by for COVID-19. So that, I think, encapsulates the simple answer. It was easier. The first things people tried worked. For HIV and malaria, the first things people tried didn't work. Neither did the second things, nor the third things, nor the fourth, nor the fifth, and onwards until today. And that is the reason why we have COVID vaccines in a year and no HIV vaccine in 40 years. So now I want to move on to what should, in an important sense, is the main part of my talk, is why vaccinate. And I want to give you a bit of the ideas of how I think about it And these are all backed up by data. These are all backed up by studies. And I'll try to share some of the studies with you within the constraints of my time. The most simple answer is a safer way to protect people from the negative effects of COVID. Even this safer, milder Omicron is the vaccine we would never license because it's too dangerous. Right now, this very safe Omicron is killing about 2,400 people a day in the United States. Okay, that is a simple answer. There is no way you could make a vaccine that does that. You would never license it. I would never license it. You would never agree to it, and you shouldn't. And that is essentially what people are saying. Oh, it's much milder. I can just get the disease. And in a free world where people are entitled to refuse the vaccine, which they are, there's a limit to what you can say to people who insist on this. Okay, but the real answer is the vaccines are safer. And everything people have said about vaccines and all of these studies that point about the negative side effects of vaccines, they're much, much rarer. Vaccines are much safer than even Omicron. You avoid long COVID. I'll show you one of the studies that shows some evidence that that's really true. You reduce the risk of infection, excuse me, and that thereby reducing the risk of giving COVID to a contact. So when I talk about this, and I will talk about this particularly with respect to Omicron, okay? There are two effects that you expect out of vaccines that make it less likely a person will give the vaccine to, give COVID disease, give the virus to another person after them. Okay, one is that they don't get infected themselves. And that's, we have some measurements for Omicron, okay? There still is some protection from infection, and I'll talk about that, okay? There are also, even those who are infected may have a reduced risk of transmitting it onwards because they're infectious for shorter times, they're less infectious, and that's less well measured and a little more complicated. And also, there's really no data yet for Omicron because it hasn't been around for long enough for people to make the right measurements and be confident in it. So I'm going to talk about the reduced risk of infection, but keep in mind, there are additional, that's probably an underestimate of how much people are going to be protected from not only getting the virus, but also passing it on to other people. So first, I'm going to talk a little bit about some side effects. And this will be my first data slide, and I'll try to take you through it a little bit. So these are what we call risk differences. The difference in the risk of acquiring an acute kidney injury from COVID, for example, over here on the left, the yellow bar, versus getting an acute kidney injury if one doesn't have COVID. That risk isn't zero, but it's very low. And what this tells you is that risk is higher. And these are displayed as number of events per 100,000 people. So these are population risks, not the risk of if you get COVID, will you get a kidney injury? And I'll talk more about that because these are underestimates for most settings because of where these data were collected. And I'll tell you about that. But what you can see here is you see a lot of yellow bars, which means higher risk from the vaccine, from COVID disease than from not COVID disease or than from the vaccine, okay? And if you go looking here and you look for where there are blue bars, here's where the risk is higher in the population from the vaccine. Now, many, many more people get vaccinated than get COVID because we try to vaccinate everybody, certainly in the setting in Israel where these data were collected. Nonetheless, these are population estimates, so they correct for that. It's lymphoadenopathy. What's lymphoadenopathy? Swollen lymph nodes. Lots of people get swollen lymph nodes when they take a vaccine. And after some days, it resolves. Swollen lymph nodes are the main side effect that was more common out of people from the vaccine than from COVID disease itself, out of everything they measured. And they measured some serious stuff, acute kidney injury here on the left, okay? Pulmonary embolism here on the right, serious, often kills people. Blood clots generally don't appear here, and deep vein thromboses appear. So some of the most severe effects of blood clots appear here. They're all more common in the population from COVID disease. So let me just talk a little bit about the details of how carefully they did this study. They took vaccinated people in Israel. they were matched to similar risk unvaccinated individual. Each individual was matched to a similar risk unvaccinated individual on the day of vaccination for the first person, and they were both followed. They were matched by age, by gender, by city of residence, and by comorbidities. Each pair was followed until one of three things happened. Okay, 42 days elapsed. That was their period. They were looking 6 weeks out from the vaccine for vaccine effects, or 6 weeks out from COVID for COVID effects, which for COVID, we already know is not always long enough. The control got vaccinated. As soon as that happened, to try to keep it even, they stopped monitoring both the vaccinated person and the control in order not to bias the data, and the date that they stopped the study, which was May 24th, 2021. So realize that in Israel, Israel vaccinated early and widely when they vaccinated early. So that will tend to accentuate the vaccine-related effects, and they had much lower COVID rates than many countries in the world. So for most countries in most settings, this is an overestimate of vaccine-related side effects and an underestimate of COVID-related side effects. And yet, what do you see coming up here? All the serious events, they're more likely from COVID and not so much from the vaccine. I think this was a key study, was very carefully done to try and avoid biases, and from my point of view, one of the most convincing studies. So this is a summary of what I've said. A risk of almost all vaccine side effects were less common from the vaccine than from COVID-19 disease itself. These are population data from a country that vaccinated widely very early and had lower case rates than many countries. Okay, certainly at the time of the study, these effects would accentuate the risk of the vaccines. And despite this, the vaccine effects are much rarer and milder than COVID-19 disease morbidity. So people have looked hard. This was a study from a health insurer in Israel who had essentially, they don't make money from vaccines. In fact, they have a very strong interest in not treating people with COVID disease. That gets very expensive. And when their insured people get sick, they pay the bills. So this was not, in an important sense, I would argue, in any way open to that sort of bias as well. I'm going to show you a little bit about vaccine side effects. There's some important study out of South Africa, the Sisonke study. 477,000 healthcare workers in South Africa who received, at that point, 1 dose of the Janssen or Johnson & Johnson vaccine. The links are at the bottom here if you pull down the slides. The serious adverse event rate was low. It was 29 per 100,000 vaccine doses. I want to pull out the two most important, what I'll call signals out of this study that seemed to me, when I read through this study, there were 4 cases of Guillain-Barré syndrome that worked out to 10.6 cases per 100,000 person years of monitoring for their 28 days from the vaccine analysis. If you look at it for the entire monitoring period, the number is lower because there was more monitoring, but there weren't more cases. That compares to a background rate in the USA pre-COVID and without obvious vaccination to about 1 to 2 per 100,000. So this looks like there is a low rate, but again, much lower rate than the risk of death from COVID, of Guillain-Barré that was picked up in this study. Still only 4 cases in 500,000 people. 2 cases of thrombosis with thrombocytopenia syndrome, only 1 within 28 days. No evidence that any of these cases were directly vaccine related. All we see is that the rate from a small number seems a little bit higher than what you expect. And that's what they reported. This is sort of a known side effect. Many of you heard about this from J&J. In fact, the Johnson & Johnson vaccine rollout was paused both in the United States and South Africa when these data first came out while they were being evaluated. So in the American data, there were 54 cases from 14 million Johnson & Johnson vaccine recipients. So that's 3.8 cases per million. Most of these cases resolve, not all of them, unfortunately. And that works out to 2.6 per 100,000 person years. And I didn't put a comparison to the background rate because that's hard to come up with. These events are so common in older people compared to younger people. What made this signal stand out was the fact that it happened from the vaccine in younger people. but still 3.8 cases per million. I can speak for myself. And looking at these information on this slide and on the slide before, you are safer getting a vaccine than driving a car in South Africa. Okay, so I think that's an important point to make, and much safer than trying to brave one's own risk, as low as one may perceive it to be, from COVID. And I think that is the important point here. Having said that, I wanted to pick out another important study that really tried to ask the question, are we missing severe negative side effects? This was a CDC study based on a population study of 11 million people at 7 research sites in the United States. It went for about 6 months early on in vaccination, with follow-up 2 months onwards. 6.4 million vaccinated individuals were monitored in this study. The first thing they did was to try to remove COVID-related deaths. So anybody who died within 30 days after a COVID diagnosis or a positive COVID death, that death was not counted. They were trying to ask, are we missing negative side effects? And obviously one of the effects you have to remove from this study is COVID deaths, because that's affected by the vaccine. People are less likely to die if they're vaccinated. The controls were followed over the same period. The Janssen or J&J vaccine group was approved. The Janssen vaccine was approved later than Pfizer and Moderna in the USA. So they had that group had their own control group separately. The comparisons were within age groups. I'll show you that. It'll fly by on the slide, so I can try to keep to my time. The short answer is unvaccinated individuals were 3 times as likely to die over the study period than those who'd received Moderna or Pfizer vaccines, and twice as likely to die over the study period than people who had received the Janssen vaccine. Here's some of the data. Again, not time to go through it. All I want you to get from this slide is how carefully and how they analyze their data. On the left side, they tell you how many people were in the group, age distribution, gender distribution, ethnic distribution. For each group, there was the Pfizer group, Moderna group, the unvaccinated controls for them, the Janssen group, and their unvaccinated controls. On the right side, you can see they try to make it all transparent. You can download the paper. Here's the link. How many people died in each group by age. Then they standardized it. They made it into deaths per 100 person years of monitoring. And in every case and across all age groups, the death rate was higher in the unvaccinated group than it was in the vaccinated group. And I don't have the time to try to go through it, and I don't expect you to squint, but you can see this, and you now know what to look for if you download the paper and want to look for yourself. If you choose to, you are welcome and encouraged to do so. So the short answer, as I said, 3 times as likely to die. Unvaccinated individuals 3 times as likely to die than Moderna or Pfizer vaccinees, or twice as likely to die than Janssen vaccinees. There's no evidence for missed side effects from vaccines that are killing people. That's what this study was looking for. But then there is a question, why did they see what they saw? So I think there's a couple of things going on here. One of them that probably is important is the study did not remove all COVID-related deaths by waiting 30 days. Some of them take more than 30 days. Certainly we know of people who've been in hospital for more than 30 days and may have survived if, or unfortunately passed on. And so not all of those COVID-related deaths are there, and the vaccinees are protected. Of course, the bigger you make that window, of course, the more likely you are to miss some deaths that you might have wanted to include in the study. So it's not clear that increasing that window, how much that helps. And there is an effect, if we really think about it, that it may be that people who choose to vaccinate are healthier. And they tried to prevent that. The unvaccinated population was drawn from a population of people that had had an influenza vaccine within the past 2 years. So they tried, but it looks like they didn't entirely succeed. Nonetheless, there's no big group of people who died because they're vaccinated. This study would have picked that up. And so although I'm not big on internet memes, I'm going to pick you one, send you one that I downloaded from Facebook the end of last August. Once again, American hospitals are filled to overwhelmed with people desperately ill with COVID-19. You know, it's not happening. Not one US hospital or anywhere else in the world is filled with people suffering side effects from the COVID vaccine, written in the middle of the Delta wave in the United States. And I think this encapsulates the point. there are not masses of people who've been severely injured by vaccines, okay? And especially when you compare them to the normal rates of whatever the effects are in the population. I want to talk a little bit, I'm now running a little over time, so I'm going to go quickly here. Long COVID, heart disease risk soars after COVID. This was a study that was described that looked only starting 30 days after COVID diagnosis. Heart disease rates go up. People also in studies I'm not going to show you from the UK have increased hospitalization rates and increased death rates for a year after hospitalization with COVID. In this case, although the rate went up with mild cases, it went up much more with the severe cases. And the authors, I think rightfully so, took that as another reason to encourage people to get vaccinated because they're less likely to get severely ill. A study from Israel looked at and tried to get people to talk about their COVID and long COVID symptoms more than 30 days after having COVID. And what they found was that the people who were vaccinated and had COVID did not have increased rates of long COVID symptoms like fatigue, for example, or difficulty breathing. They didn't have increased rates of that long after their COVID episode, even compared to people who'd never had COVID. Okay, and certainly those rates were much lower than people who had COVID when unvaccinated. So it does seem that being vaccinated, if one gets COVID later, because that is possible, makes one much less likely to get long COVID. And because these happen over a long time, they're often missed in the studies that look for benefits of vaccination. Indirect protection. How likely am I to give COVID to somebody else? This was a very interesting study and well constructed. Does vaccination of parents partially protect children from being vaccinated? This, also done in Israel, comes from a period of time when vaccination was not offered to children. So let me take you through this very quickly. On the left is 0%. From left to right, that's no protection. Up here on the right is 100%. The dot is their estimate. And the line with the error bars here is the range in which their estimate most likely fits. Red corresponds to protection from one parent being vaccinated. Blue corresponds to protection from two parents being vaccinated. So not complete protection, but still looks very substantial. They look during a period when Alpha was dominant, during a period when Delta was dominant. And this is all broken down by age group, seems to persist in every age group, even the young ones to the older ones, and household size. It also persists despite changes and differences in household size, which might change the contact dynamics. So children were less likely to get COVID if their parents were protected. And that is part of the answer. It wasn't complete. There were still cases. These are numbers like 58%, not 100%, but there were many fewer cases. What about Omicron? How well do vaccines protect against Omicron? So far, there is one study done in a period and in a place where Omicron was largely the only variant around. The American studies that are out so far, there was still a lot of Delta. The original study published in New England Journal of Medicine, here's the link, with some explanatory commentary from a press release from Discovery Health, which is one of our insurers here. 2 doses of Pfizer vaccination without booster. A lot of the American Israeli studies are about boosters. This study is not, because we were not offering boosters yet here in South Africa. 70% protection against severe complications requiring hospitalization. 33% protection against COVID-19 infection. The New England Journal of Medicine study, the original study, shows the entire analysis for the 70% protection, and they try to check if they've really got their answer right. If you read the study and you want to know more about it, I found it very hard to read myself. If you have questions, you have my email address. These are likely underestimates because researchers had access to individual vaccination data only till about 3 months before Omicron hit here. So anyone who was vaccinated in that 3-month period, to the study, people looked unvaccinated. So they essentially had vaccinated, protected people in what they thought were in the group of people who they thought were unprotected. So the real numbers are probably larger because some of the people in their unvaccinated group that they called unvaccinated were actually vaccinated. So that's something to keep in mind. The last thing I want to show you is some data that was published in the New York Times. There's a long link here If you get the slideshow or ask for the link from me or the organizers, this link will link you free to this article, the whole article, until February 22nd. And what you can see is in the number of cases. These are cases per 100,000 population, so it's a case rate. And vaccinated people in both cities were more likely to get Omicron, more likely to be hospitalized with it, and more likely to die with it. So why vaccinate? You protect yourself or the person you vaccinate, depending whether you're getting vaccinated or you're vaccinating someone else. The protection is better for hospitalization and death from COVID infection. You're protecting others around you. 30% protection against infection with Omicron means at least 30% protection against infecting somebody else. If I were caring for an elderly parent and I'm in a position where I've had to think about this, I would get vaccinated just knowing this and nothing else. I'm less likely to kill my mother with COVID. It's a very simple calculus if I'm vaccinated. It may not be as much as I'd like, but I am less likely. For healthcare workers, protect your patients. Vulnerable patients seeking healthcare deserve that same consideration that I want for my mother. Hospitals must do their best to prevent spread of COVID-19 within the hospital setting. Now, we all know that Omicron spreads even in vaccinated people, but it spreads less so. And everything that can be done to protect people, especially in hospital and healthcare settings, I'm of the strong opinion should be done. So I strongly urge all of you to get vaccinated if you're not. And I strongly urge you to, with this new information, to feel convinced you're doing the right thing when you encourage people to get vaccinated. And here I'd like to thank all of the people who contributed in any way to this talk. Some of them don't even know it. I got information from seminars that they gave. Some of them gave me material I've included. Some of them just changed the way I think. And with that, I'll stop here and apologize for going over time. Thank you.
Thank you very much, Prof. Dorfman. And I think you will see there's a lot of questions in the Q&A box, and I think a lot of them won't be able to answer today. I'm just going to do a quick health break. It's just a 3-minute, just to give the interpreters a time to just raise their voice. So if you can just stop sharing, then I can share with them the health break just for them to breathe a minute. So we're just going to quickly play the video just to give the interpreters a time to be able to raise their voices. So can you hear it?
Sorry, I have no sound.
Okay, so let me just stop sharing and start again. So if there was no sound, just want to push up my sound. It might be that.
Against infectious First came the virus that had never been seen before, and that spread faster than we could ever imagine. Now we hear there's a safe and effective way to stop it. Vaccines that will protect millions from COVID-19. But can we really know they're safe after less than a year of testing? COVID-19 vaccines may be new, but vaccines are not. We've been using vaccines to protect against infectious diseases for over a century. 2 COVID vaccines are the first authorized vaccines ever to use a new technology, but even that technology, called messenger RNA, has been tested and studied by vaccine researchers for decades. We've learned how to make vaccines better and safer, and we've applied all that knowledge to COVID-19 vaccines. We also had a head start on COVID vaccines thanks to studies the National Institutes of Health had done. Scientists there actually created a vaccine that could be custom made to fight different strains of coronavirus, like the virus that causes COVID. Using these studies, they were able to make a COVID-19 test vaccine just over a month after the disease was first reported. All vaccines have to be thoroughly tested before they can be marketed. During clinical trials, scientists measure and compare data on volunteers who receive a vaccine to those who receive a placebo, like an injection of saline. Most early clinical trials involve fewer than 3,000 volunteers, so it can take a year or more to get the data needed to measure how well vaccines work. Early clinical trials for COVID vaccines enrolled at least 30,000 volunteers each, so data on safety and performance were collected and analyzed in under 4 months. Vaccines are usually developed one step at a time, and companies wait until they have final approval to start manufacturing them. But addressing this pandemic couldn't wait. So government and industry invested millions of dollars to produce vaccines at the same time their test data was under review. This meant health departments and
Sorry, I'm not sure why that happened. But I think we've got a time for our interpreters to just save their voices a little bit. And I want to hand over to our next speaker, Mrs. Dorika Nyamba, from the chairperson and president of the Infection Control Society in Malawi. And she's also working as a health service manager at the Christian Health Association of Malawi. And she's going to give us just a little bit of experience from Malawi on the vaccination as a healthcare worker. Over to you, Dorika. Just unmute yourself.
Okay. Thank you, Anne. Okay, may you stop sharing your screen so that I can share mine?
Okay, here you are.
Okay, good afternoon, everyone. So Dorika Ngambi, as Anna has already said, I'm just going to share with you our experience in Malawi on the healthcare workers' power in building confidence in patients and vaccine uptake. So my outline is a vaccination status for healthcare workers, sources of information on COVID-19 vaccine, reasons for not getting vaccinated, building trust in COVID vaccines, pillars to building confidence, strategies for building confidence, and building community confidence. So as of 8th February, that's how we stand as a nation. The one that you see in red, that's our statistics as national vaccination that has happened for healthcare workers. So as Malawi, we stand at 66% of healthcare workers have been fully vaccinated by the 8th of February. And just for information, we started our vaccination in March last year. So the reliable sources of information that patients and clients and guardians rely to as follows. This was revealed by a study that was done in the US. And they say that the most reliable source is the personal doctors. Most people trust what their doctors tell them. And the next reliable information comes from employers and health insurance companies. And some trust their local public health department. In our case, people trust the information that is issued with the Ministry of Health. And some trust the websites. So since the healthcare workers are the most trusted sources of COVID-19 information, we urge that all licensed healthcare professions should talk to their patients about COVID-19 vaccines. So this can be done for, it's one person at a time, one conversation at a time, and it's one vaccination at a time. Let us all utilize the opportunities that arise that we meet patients. It might be during diabetes check, blood pressure check, or knee repair, or even under 5 clinics. For us, we also utilize those opportunities where healthcare workers can talk to the guardians, to the mothers, about the need to get vaccinated. So when we try to get also the reasons why people are not getting the COVID-19 vaccine, some worry about side effects and the newness of the vaccine. And I'm happy that the prof tackled this much pretty well. And then I'm sure all the people attending this webinar have now the right information to give to our patients and our clients. And thinking that they do not need a vaccine, that's another reason. Not believing and trusting that COVID vaccines are safe, as they also developed within a short period of time. And medical reasons for not getting vaccinated. In this one, we had people saying that, no, for me, I'm asthmatic, so I cannot get vaccinated. So it took the healthcare workers to dispel that actually, if somebody is asthmatic, it's very important that they get vaccinated because it's one of the priority groups. And then some people are just too busy and have no time to get it. And for us, for this reason, mainly we took the vaccine where we can find people. We took the vaccines to the bus stations, we took the vaccines to the markets, we took the vaccines to the shopping malls, just to make sure that people who are busy and have no time to get it, they can get vaccinated in those areas. Some people don't like getting shots, and some are worried about missing work. About missing work, we tried to also go to the main workplaces, like for our government, we have a complex which houses all the ministries, the major ministries. So we even set up a vaccination center in that area just to make sure that people get the vaccine right there where they're working. And then some people were saying that it's difficult to travel to the vaccination sites and we're worried about paying. So on the vaccination sites, we put in a lot of them, even in the remotest area, by using our health surveillance assistants who were able to give the vaccines to those remote places. So it's very important that we know these reasons so that we can help as healthcare workers. We have to dispel these reasons which people give. Some of them are myths. So if once we know the reasons, we are able to build confidence in our patients by telling them the right information. So what is building trust? So building trust in COVID-19 vaccines is vaccine confidence is just the belief that vaccines work, are safe, and are part of the trustworthy medical system. So this is what vaccine confidence is all about. So we as healthcare workers, we are supposed to tell the patients, tell the clients that vaccines work and are safe and are part of a trustworthy medical system. We've clearly heard the professor explain this in more details. So there are 4 pillars to build confidence. So if you are already vaccinated, become a vaccine champion, share your reasons for getting vaccinated, and encourage others to get vaccinated. And this being a champion means that you can be a champion wherever you are, a vaccine champion wherever you are. You got vaccinated as a healthcare worker, you go to church, you can talk about the vaccine and encourage people there to get vaccinated. You go to the market, you go for games. Anywhere where you go as a champion, you're supposed to make sure that you share the reasons for getting vaccinated in such that you should encourage others to get vaccinated as well. Then number 2, talk to your friends and family about getting vaccinated. You can use CDC resources to help you talk to others about COVID-19 vaccines, because sometimes you find that there are some myths that people come up with, which you may not have the right answers. It's better to say, okay, I'll look it up and then check with the reliable sources and then get back to the people that asked you questions so that you can really encourage them to get vaccinated. But also it's very important to listen to their concerns with empathy and answer their questions about vaccinations truthfully. And number 3, address COVID-19 vaccine misinformation. Then pillar number 4 is celebrate and share the decision to get vaccinated. And in the picture, it's me getting vaccinated. And I was one of the first people to get vaccinated when we just started the vaccination in Malawi. And I shared this picture on my WhatsApp status, and it got other people to get vaccinated as well. So let us use social media as well so that we can get more people to get vaccinated. And information that comes from a healthcare worker is very much a trusted source of information. So please let us share our vaccination stories and get more people vaccinated. So the other strategy that you can use to build confidence as healthcare workers is we can use the abbreviation, which is said as SAVE. So S is you have to seek patients' COVID-19 vaccination status verbally or through immunization records at each patient encounter. And A, you can ask or educate unvaccinated patients about the vaccines and offer more information if they're unsure. And the V is to vaccinate patients who agree to be vaccinated or refer them to the COVID-19 vaccine provider. So suppose you're seeing a patient in your consultation room, and then you talk to the patient, and then the patient agrees that they want to get vaccinated, and you don't have the vaccine right there with you. You have to refer them to the section of the hospital where they can get the vaccine. And if possible, if you have porters or you have people that can escort the patient to where they get the vaccine, that would be the right thing to do. Or you can just give them directions. But sometimes if you just give them directions, somebody may just leave your office and maybe they would like, okay, I'm not going to get the vaccine anymore. So let us vaccinate patients who agree to get vaccinated. And the E is to empower patients and staff to share their vaccination status with their friends, families, and communities. Building vaccine confidence in communities. It's very important to reach out to eligible patients, especially those from communities who have been highly impacted by COVID-19. And also have to use community-specific resources for outreach and engagement. For example, for us in Malawi, for this one, we were using even mobile vans, which would share messages, would have people sharing messages about the importance of getting vaccinated, and would even have people going actually into the actual communities, door to door sometimes, or reaching out to when people are in funerals or in churches, so that we just make sure that the information about the vaccine reaches the communities. Then you also have to meet people where they are with a goal of vaccines going to people and not people going to vaccines. I think I've already explained on that one. Then you also partner with local trusted community organizations or structures or groups and with your local health department to coordinate vaccination events. For us, we also saw that partnering with even churches and mosques also helped in getting people vaccinated. So we had the faith leaders talk about vaccinations also in their churches or in their mosques, just to make sure that this vaccine confidence is there in the communities. Thank you for your attention. That's what I had.
Thank you very much, Dorika. It was wonderful to hear the feedback from Malawi. I'm going to hand over to Dr. Aryo Bakare from Africa CDC. He's going to take over the questions and answers. If I'm still correct, Aryo, over to you.
Good day, everyone. I'm Dr. Aryo Bakare from Africa CDC. I'll take us through the Q&A session for today. Big thanks to our presenters and the facilitators. Pharmacist Ezine has built our confidence. She has shared some strategies on how we can help our patients to get the expected protection from the ongoing vaccination campaign. Thank you so much, Ezine. Professor Dorfman, thank you so much for your presentation. So wonderful. Prof, you have taken us through the scientific background, which vaccine is which, and the dilemma around COVID-19 vaccine, and recent findings from research on COVID-19 vaccine. Thank you so much. And Dorica as well. She talked about, she has done justice to how we can build confidence for COVID-19 vaccination in our communities, how we can use SAVE to increase these modalities that we have adopted. Thank you so much. Africa CDC is trying to make sure that we don't leave any stone untouched to make sure that we boost COVID-19 vaccination in Africa. You can see that why many developed countries are celebrating 60 to 70% coverage for the booster doses. Africa countries are experiencing declination. So the vaccination here is declining. And unfortunately, healthcare workers' infection continues to increase. So we need to work more on how we can use all the knowledge we have gotten from here today. Let me, because of our time, let me go quickly to the questions. This question will go to Professor Dorfman and Ezine probably, if she can add to it. And it's from Mohamed Abdullah and Kolibali Nabembin. I don't know if I pronounce your name well. So they want to know more about RNA vaccine and how it works. Over to you, Prof.
Okay, this is the sort of question that is easier if I prepare for it because pictures are sometimes worth 1,000 words, but I'll try my best in words. Are the cells in our body, in order to maintain themselves and perform their functions, they all make proteins that are important for sensing their environment, for things they secrete as part of their function, as part of the body. All of this involves making proteins. And the way cells make proteins is they find the gene for that protein and they make a copy of that gene in RNA, and that's called messenger RNA because it takes the message from the nucleus where the DNA is to the part of the cell where the proteins are produced. And then that messenger RNA is part of the process of building those proteins. And that's true for every protein that is made in every human cell, and in fact, in every cell of every organism. What the vaccine does is it provides the cell with RNA that codes for the SARS-CoV-2 spike protein. And the RNA has to be treated, it has to be coded so it doesn't go off, it doesn't degrade. And so it can get into a cell. But once it is there, it's treated like other RNAs, and it directs the production of some spike proteins. And it is those proteins that immunize us. We're then exposed to it, and we make immune responses to it. And I hope that's a fuller explanation. Some of these things are easier with pictures, and I apologize, I don't have anything prepared. I hope that's enough.
Thank you so much, Professor Dorfman. Ezine, do you want to add to that?
No, I don't. Really, pictures would have done a better job of explaining.
Yeah, okay. I think Prof has done justice to that question, and there are more information about that online as well. If Mohamed Abdullah and Kolibali want to venture into that, there are more questions. So I want to direct this question to Dr. Ronnie. Dr. Ronnie has been one of our panelists, is the IPC National Focal Point for Uganda, and has been with us for some time. This question is from Mr. Augustine Casterodi from Namibia. So I know Ezine and Professor Dorfman, they have addressed part of it, but is concerned about low vaccination coverage in Africa. And it's two questions in one. says, what is the cause of vaccination hesitancy? And the way things are going, does it mean COVID-19 is becoming endemic in Africa, just like malaria? Over to Dr. Rooney to answer those two in one questions.
Thank you so much, Dr. Rio. The biggest contributor to vaccine hesitancy has been a lack of understanding of the science behind how the COVID-19 vaccines were made, which has been demystified by Professor Dorfman, especially where people were wondering how quick the vaccines were invented and taken through the whole entire process of vaccine production. When we all are aware that the process of vaccine making or manufacture is a long-term process that goes through series or stages of approval, stages of vetting, and yet for the SARS-CoV-2 virus vaccines were made and approved within 1 year, just like Professor Dorfman indicated, that within 1 year we were able to get these vaccines. And basing on the myths that have been happening where people have been talking about the New World Order, the end of the world, and how certain spheres of wealthy individuals in the world are trying to control other people. We've had a lot of anti-vaxxer information that has been going on, and like was earlier indicated, many a time we as healthcare workers or the proponents of vaccination have not been able to utilize all the available opportunities to us to make sure that we not convince, but avail facts to enable people take decisions that are informed to improve vaccine uptake. And that's the reason why the anti-vaxxers have been moving way ahead of us. But from Professor Dorfman's presentation, we all now can understand what the process of manufacture or making of the SARS-CoV-2 virus vaccines were, and what it entails, and how it comes in to demystify all the anti-vaxxer messages that have been going around, how we're being inoculated with some chemicals against which we should be controlled as human beings, and us being turned into robots. So as healthcare workers, I believe it has been a lack of information or a lack of understanding of facts, and that's the reason why there's been a lot of hesitancy, not only amongst healthcare workers, but even the population, because remember, the masses believe in us as healthcare workers. And that's the reason why we need to take lead in such campaigns. But if we ourselves are hesitant, then that means we are actually increasing the hesitancy amongst the ordinary people that look up to us as healthcare workers. So in my opinion, that's what has largely contributed to the vaccine hesitancy across the world and across Africa largely because of those myths. And then SARS-CoV-2 or COVID-19 becoming endemic, by and large, that's what we are seeing. And with the Omicron wave that has just swept the world, and how it came in a little mildly, and how people were infected and recovered quickly, we're hoping that maybe that's where we shall go. So Professor Dorfman, as a medical virologist in this would guide us on better, guide us better on how we should look at SARS-CoV-2 with the advancements of the mutations that are emerging from the original virus strain that we received as a country, as a world. Thank you, and over.
Yeah, thank you so much, Dr. Rooney. Because of our time, I think that is enough for that question. We might not be able to call on another panelist to add to Dr. Rooney's comments. I would like to move to another question. We have little time remaining. This will go to Ezine and Professor Dorfman, please. Kolibali want to know which vaccine is the best among the multiple choices that people have currently. That's the first one. The second one is, you want to know why do we have many vaccines for COVID-19 alone? And for other diseases, we have just one vaccine for one disease. Why do we have that? I want pharmacist Ezine to comment, then Professor Dorfman. Over to Ezine.
So for me, the best vaccine is the one that is most available to you at that moment. There is no best. There is no that is better than the other, but that's most available to you at that point in time at that vaccination center. That is the best vaccine available. And also for the next question is that we question that we had a lot of given the situation and how COVID started, there was a need for us to have a lot of vaccine candidates because we were dealing with something we've never dealt with before. And that's why there seem to be so many, but not really so many, but quite a number of vaccines for COVID-19, because there were a lot of candidates that were put into trials and a good number of them did well. And because we were dealing with something new, we were trying our hands at different things. And that's why we ended up having quite a number of them. And we're still trying now to fine tune these ones we have already and trying out new technologies to see what's better and what can give us lasting protection. So over to Dr. Hoffman, Professor Hoffman, for more information.
Thank you, Ezine.
Thank you so much. Over to Prof.
Thank you, Ezine. Sorry to talk over you. I think I will second that. The best vaccine is the vaccine that is in somebody's arm and is working. And all of these vaccines are better than no vaccine. And we could quibble and we could say, oh, which one has the best data, this, that. And maybe at some level it's worth it, but the simplest answer and the best answer is each of these vaccines is better than no vaccine. It gives people at least some protection. And I think that's the important message. And that's very much the same answer that Ezine has been giving. And the second question, please remind me.
The second question is about why do we have multiple vaccines for COVID-19 and other diseases? We have just one vaccine for one disease.
Yes. The example, I think I'll use the example that the questioner gave because I looked in the Q&A of measles. Okay, there used to be an inactivated vaccine, like some of the ones here, that there was for measles, and it didn't work as well as it should. And it was stopped being used a little more than 50 years ago. And at that point, there were really only two ways to make vaccines. There was inactivated, there was live. And the live vaccine is the one that worked better. So it is the one that has been used all these years. And because it works and works very well, we have kept using it. Now, there are also many more ways of making vaccines. There are also, and so there were many more opportunities. And each vaccine you have is one company or one country that has tried to make a vaccine, and nobody left it just to one group. So there were many people at the same time trying to make vaccines. And this was encouraged because for all we knew, one would work and the other 10 wouldn't work. I mean, we have every reason to think that might have been true. And so many, many different people tried to make vaccines. Many of them are coming onto the markets. And that's why there are a large number. For measles, there really just weren't a lot of options. There were essentially two options of how to make it, and one of them worked better than the other, and that's why we have one. Just to give an illustration, for the more recent vaccines, sometimes we have two or three, because what we see with COVID had already started happening. All right, thank you very much.
Thank you so much, Prof. There's a question here that says, how long does one tested positive case wait to get COVID-19 vaccine? I'll quickly answer that. It is just after 7 days, the person is discharged from isolation. 7 days from the person when the person is discharged from isolation. There are a lot of treatment protocol that backs that. So I don't want us to waste time on that one. This one says, how long does COVID-19 vaccine protect individuals? And when are we going to have a lifelong protection from vaccines against coronavirus infection? Pharmacist Ezine, can you say something to that?
There are a couple of things to look at when you're looking at how long a vaccine protects. We're looking at antibodies because that's what's